Hello, and thanks for watching this video series on engaging primary care and opioid process improvements. This video will provide you with the landscape of what's currently happening in Alberta with regards to the opioid crisis. We provide some facts about who's most affected and where the problems are occurring.
Many people believe that the people dying from opioids are not the people typically being cared for in primary care, or that it's not a primary care problem. So who is the face of the opioid crisis? We're going to take a look at the demographics of Albertans who are most affected by the crisis. Luckily, Alberta has the most accurate data in the country, as the Ministry of Health tracks various factors related to opioid use, including emergency department visits, prescription dispensing, and death information. Information on deaths, which are acquired through the Office of the Chief Medical Examiner, are reported quarterly.
These stats show that of the illicit opioid deaths, 79% were young males, which one might expect.
However, of the non-illicit opioid deaths, there was an even split between genders and an even distribution of ages.
Further to that point, we see from the 2016-2017 stats that 55% of opioid-related deaths, both illicit and non-illicit, occurred in people aged 20 to 39, with the highest incidence being those in the 30 to 34-year-old range. While that age group might be expected to have the highest incidence, notice that 45% of opioid-related deaths occurred in people over the age of 39. Therefore, it might surprise you who could be affected by this public health crisis.
From the stats collected, we see opportunity. Of the opioid-related deaths in Alberta in 2017-18, 67% of those who died had received their opioid from a community pharmacy within the previous month. From this, we know that these patients had a prescription for opioids and were therefore interacting with the healthcare system. This interaction provides us an opportunity to start having a different conversation with patients from the time of initial prescription or prescription renewal.
In response to the crisis, we saw updated guidelines come out from the Centers for Disease Control in the United States and the Canadian Opioid Guidelines for Chronic Non-Cancer Pain in Canada to provide some guidance around prescribing of opioids. In the U.S., policies have been created that have misapplied the CDC guidelines, which led physicians to be scared of prescribing opioids at all. While Canada has not legislated strict policies, Canadian doctors are following what is happening in the U.S. and may be resistant to these new guidelines. Additionally, within the last few years, the College of Physicians and Surgeons of Alberta came up with a new standard of practice around prescribing medications with potential for misuse or diversion, such as opioids and benzodiazepines. The standard of practice outlines rules and recommendations to be followed in order to protect the public and in turn the physicians prescribing these medications. With this, the CPSA sent a letter to all physicians who prescribed opioids, highlighting instances of high dose as a way to bring about awareness. This letter, called the MD Snapshot, was meant to be non-punitive, non-judgmental, and a tool that can be used for quality improvement.
This slide outlines what is included in the MD Snapshot. Specifically, it includes the number of patients to whom the physician has prescribed opioids, the total OME or oral morphine equivalent per day that was prescribed, the average OME per day per patient, the number of patients receiving one or more opioid and one or more benzodiazepine prescribed by the physician, the number of patients receiving opioids at an average dose of greater than or equal to 90 OME per day, the number of patients receiving 3 or more opioid ingredients, and the number of patients receiving opioids from 3 or more prescribers.
You can see a sample of the MD Snapshot on the ACT website. The snapshot includes individual physician data as well as a comparator group from their specialty.
When illicit and non-illicit opioid-related deaths are tracked over time, we noticed a correlation before and after the CPSA standard change. We want to preface this by saying that the trends are observed correlations only, and we can't draw any conclusions about causation. However, what we noticed was there was a decrease in non-illicit or prescription opioid-related deaths after the CPSA standard change in the third quarter of 2016. Additionally, there was an increase in the number of illicit opioid-related deaths after the CPSA standard change. One could interpret this as more patients having to turn to illicit opioids as a way to replace their previously prescribed opioids. However, we can't know if it's just merely coincidence.
When we think about opioid-related deaths, one might assume that this is a downtown or an urban problem. But by far the majority of deaths did not occur in the urban core. In fact, in Calgary, 88% of the deaths occurred outside of the downtown urban core, and similarly in Edmonton, 80% of the deaths occurred outside of the urban downtown core.
In 2017, in the Calgary Zone, there were 224 opioid-related deaths. If we look at the two red zones, which actually represent more than the true downtown core, they account for 30% of the opioid-related deaths. This means that 70% or more of the opioid-related deaths occurred outside of the downtown core.
And Edmonton looked similar. While they had fewer opioid-related deaths, the majority were still occurring outside of the downtown core.
Finally, we can see that 56 and 51% of deaths occurred at the patient's home address. This creates an opportunity for primary care in the promotion and distribution of take-home naloxone kits. Thank you for watching. The next video in this series introduces some compelling information that can help when engaging primary care physicians and teams in opioid process improvement.